The last year, we've seen amazing developments in the world of therapeutics in diabetes and how some therapeutics appear to impact cardiovascular outcomes. For years, we've been searching for the medication that could do both for us: prevent the number one cause of death in diabetes patients, which is heart disease, and treat the diabetes. So patients could get more bang for their buck, but also we wouldn't be in the position, 30 years into the disease, having to revascularize patients, which is difficult. Patients with diabetes, specifically type 2, develop really difficult cardiovascular disease problems, heart failure, and then when we go to try to fix it, it's not as easy, and they have what we call the diabetic disadvantage at that point. Really some cool stuff. We have one drug called empagliflozin. This is a drug in a class called the SGLT2 inhibitors. And there's a new study that recently came out called the EMPA-REG trial, showing a very early separation in the curve between patients with diabetes who got the drug versus those who didn't. There's a mortality benefit from that drug. And it looks like most of the mortality is related to heart failure outcomes, like hospitalizations and then subsequent potential death from that, in that setting. It's probably not just all heart failure, though, because the patients entering the trial were not known to have heart failure in general. And it happened quick. So we're trying to understand why. It may be neurohormonal. As an endocrinologist, I tend to think that it's probably related to the renin-angiotensin system or other types of modulators that are activated with that drug. We also have some pretty interesting outcome data from the LEADER trial, which is not out yet. It's officially out in June. But I had an opportunity to speak with some of the investigators today, and the top line results are public, indicating that 80% of the folks in that study, which is a similar study, no drug, placebo, 80% had advanced heart disease. And it looks like there's a mortality benefit. And that drug that they're studying, which is liraglutide, is a drug that I use as a diabetologist very frequently. It's a highly effective diabetes drug. So we might be able to say to a patient soon, if not already, that, I can control your diabetes and I can protect you from a heart attack and maybe even a stroke. So this is something I couldn't say literally a year ago. They're both approved. They're both approved drugs. These trials that are coming out, they're very large, thousands of patients being enrolled. They're called cardiovascular outcome trials. The reason they're being done is not to approve the drug. It's to prove that they're safe from a cardiovascular perspective. So since 2008, the FDA has required these very large, expensive studies. And a lot of us, including myself, thought, why are we spending all this money on these large trials? I understood the value on the surface, but these drugs are highly expensive, very expensive. And the cost of developing the drugs goes into the final cost that the patient sees. But now I'm sitting here, with my tail between my legs saying, I'm so happy that we did this because I can actually apply it to the clinic. I just had this great conversation with Allison Bailey, who is, she's on the committee here at ACC for preventive cardiology and developing curriculum in that. And she and I had to discuss this exact thing. And we think that we may get to a point where we're developing, we use precision medicine, meaning we say this patient is ideal for these two medicines, this patient's for these two. Instead of blindly treating and maybe actually using an appropriate triple therapy, maybe there's a dual therapy for some patients who, if we start early enough, they get much more benefit. So ideally, even if the cost is a little higher up front, over time, the cost of the disease will go down, and that'll translate into the drugs. We have a lot of concern around that hypothesis because it hasn't borne out quite yet. But I do think that if we can develop a more precise cocktail approach to treating type 2 diabetes, depending on the baseline cardiovascular risk, it might be cheaper for some patients, just because we won't be doing trial and error as much.